This program is brought to you by Emory University.
Good morning, everybody. Welcome back to another year of Friday Morning Fellows Conference. We will start today with Dr. Colin O'Brien. Colin, I would imagine most of you know who Colin is at this point, but he is a second-year fellow in our clinical track. Colin came to us from Beth Israel in Boston, where he did his residency, went to medical school at Stanford, an undergraduate at Brown University. And he, as you can see, is going to talk to us today about diastolic functions. I told him when he told me about this, it's not the sexiest topic in the world, but it's got a lot of teeth to it. So I'm looking forward. There you go. I misquoted myself. All right. Well, good morning, and thank you, Colin, for talking this morning.
Okay, thanks. I'm happy to kick off the year as the first fellows talk, hopefully not by setting the bar too low for everybody else. But the title of my talk is Diastolic Function. Like Dr. Williams said, I know it's probably not a title of a talk that has everyone jumping out of their chair with excitement, but it's really something that I felt I didn't know that much about before I started preparing this talk. I learned a lot throughout it. It's really not that sexy, but hopefully you'll find it important. Hopefully you'll find something in here that's useful to your practice. Okay, so let's see. Get this to work. There we go. So I'm going to start just briefly with two kind of quick case presentations. So this is the first one. This is a 68-year-old gentleman. He presented to Grady, and he had pretty minimal past medical history. So BPH arthritis, basically endorsing 4 months of worsening dyspnea. And as part of the workup for the dyspnea during his hospitalization, he had a TTE ordered. I'm going to just show you the 4-chamber if I can here. Let's see. Yeah, there we go. So as you can see briefly here, he's definitely got thick walls. So his read as normal EF. It looks like his atrial size, both the LA and the RA, are probably a little generous. So I'll show you some other clips here. Here we go. So here's the pulse wave of the transmitral flow. So you can see an E to A ratio calculated here at greater than 2. It's 2.2. Sample size maybe not ideal, but probably still holds. So here is the E prime velocity at the septal annulus here. So this was calculated at 4.4, which is obviously low, and that gave us elevated E to E prime as well at 15. And then a TR velocity at 3.2, giving us an elevated pressure gradient here, suggestive of elevated right-sided pressures. And then last but not least, left atrial size actually calculated at normal here, but maybe a little underestimated. It looked bigger in some other views. So collectively, this echo was read as probably grade 3 diastolic dysfunction. In part because of that, and obviously some other factors, he actually went down a pathway for amyloid workup. He had a technetium-99 pyrophosphate scan. You can see sort of representative images here showing avid uptake and the myocardium, read as a fluoridly positive scan suggesting of cardiac amyloidosis. And then because of that and serologic studies that weren't suggestive of AL amyloid, he was ultimately diagnosed with ATTR amyloid. And this gentleman was started on tafamidis. This was just a few months ago, so he's actually ended up being a really interesting case. He's got kind of like terrible arthritis, and his rheumatologists think that's amyloid arthropathy with joint erosions and things like that. So he's early on in his treatment course, yet to be seen, if the tafamidis will make a difference or not. But certainly an interesting case, and I think one where, although certainly not the only factor, his echo findings of severe diastolic dysfunction were part of what tipped the team towards pursuing this workup for cardiac amyloid. Okay, so here's a second pretty brief case. So this is a woman who was referred to me in my clinic at Grady, lovely 94-year-old woman. So she was referred to me after a hospitalization where she presented with dyspnea and swelling, and her primary diagnosis was acute heart failure with preserved EF during that hospitalization. Other medical issues: progressive CKD, chronic AFib, anticoagulated, asthma, hypertension, but overall extraordinarily healthy for her age. I'll show you the 4-chamber on her echo that I took a look at it, before she showed up in my clinic. So image quality, obviously not as good here. Can't really see the right side. Her walls are maybe a little bit thick as well. Looks like some mitral annular calcification. Left atrium kind of looks big again here, and normal EF. So I'll show you other images here. So I mentioned she's in AFib. She's in chronic AFib here. So no E to A ratio. We have no A waves here. And then TR velocity for her was kind of a little more borderline, pressure gradient calculated at 31 here. And then we have a left atrial size that's severely dilated here. Like I said, she had been in chronic AFib for many years. In this echo, she actually did not have mitral annular velocities. So there was no tissue Doppler done in this study. Not totally sure why, but this was the echo that I had to work with. Really, there were 2 echoes. They looked identical. Neither had those measurements, and then neither really reported on diastolic function at all. So I kind of looked at this before she showed up to my clinic and said, I don't actually really know if she has diastolic dysfunction at all. I was kind of wondering where the diagnosis of heart failure with preserved EF came from, sort of where that originated from. So I just looked back at notes. What I could find is that people had written she has dyspnea, that her dyspnea was from heart failure with preserved EF, and then that heart failure with preserved EF was from pulmonary hypertension. So all in all, kind of left me scratching my head a little bit. I was thinking as she was coming into my clinic, I don't even really know if she has heart failure with preserved EF, or maybe she just has asthma and CKD. I don't really know if she has diastolic function, and it kind of exposed that I wasn't really sure what to do with her. I wasn't really sure I understood what we were looking at with these images, these echo images with diastolic function, and that's kind of part of why I want to look into this more. So for any of you that were here last year, were able to see my talk last year, we had this incredible case. It's an bedside echo from overnight that we had, and this really fascinating patient that had a clot in transit through a PFO. Interesting diagnostic and therapeutic dilemmas. So you may be saying, why are we going from that to a little old lady whose legs are swollen? Why would Colin do this to us? And the reason I wanted to focus on this topic, even though it may not be, quite as thrilling as last year's talk, is really just because I think that diastolic function to me is something that seems like it's not always well understood, partially within the cardiology world, but certainly outside of it as well. And it feels like, we've all had this patient that I had in clinic where they kind of come in with the diagnosis of diastolic dysfunction or heart failure with preserved EF, and it's never really clear how they got that diagnosis. It's not really clear whether that's true or not. And I think, for me, as I get more of these patients in my career, and all of us will, I was thinking, I just want to understand as best I can, what is diastolic dysfunction? How do we evaluate it? What are we actually looking at when we evaluate it? And how can we sort of help our referring physicians understand this better? And I think that kind of takes us understanding it really well in the first place. So I'll start just by putting out a few almost conclusions at the beginning of the talk. The first is that heart failure with preserved EF, diastolic dysfunction, and filling pressures are not all the same thing. They're all definitely related, but they're not the same, and I think often conflated. And the second is that measuring diastology with imaging is really difficult. And so I'm going to talk a little bit about diastology. I'll also kind of mostly focus on echo assessment of diastology, since that's often where we run into this. And hopefully that'll be useful to you. Okay, so just briefly by way of history, I just wanted to highlight a little bit of the evolution of assessing diastology with echo. So this is a paper back in the early 80s, not so far after we first started using pulse wave Doppler. There was reporting on transmitral blood flow and how that can reflect diastolic behavior. This is a Japanese group, and really one of the first articles that used pulse wave Doppler to assess for diastology. And I just clipped a couple of their really great graphics in this early paper that showed E to A reversal, in certain patient subpopulations, and this one in myocardial infarction. So this is kind of the beginning, and I think there was some excitement that we could actually be using echo to assess for diastology, which wasn't really known before this point. Fast forward a little bit, if I can. There we go. To a different paper that's 15 years later, so quite a bit later. This is a paper by some of the leaders in the echo world that took another look again at diastolic function using echo, and this really turned our thinking on how we were assessing diastology with echo. And this again is like a really interesting paper that just kind of goes through like this laundry list of exceptions to the rule that we had before, which is that E to A reversal is, a sign of diastolic dysfunction. This, I just clipped like one small of many figures that they had in this paper that just shows that sort of your E to A ratio is dependent on age, which is not even something that was totally understood, well before this. And then they go through a number of different examples. And so then it kind of throws a wrench into this understanding that we had that we could use pulse wave Doppler and other findings to assess diastology, and kind of this group saying it's actually a lot more complicated than that. And then the last one I'll show you is just a year later with similar authors here. And the reason I wanted to show this is this was 1988, and sort of towards the beginning of correlating echo findings with invasive measurements of filling pressures. And I think this was the beginning of a huge field in echo research, where people started saying, let's figure out how reliable these echo measurements are. The M1 that you see on the x-axis here is correlates to the E velocity. So this is, correlating E velocity with wedge minus LV minimum pressure. And we'll talk more about other papers that have taken this approach as well. So then we get to 2009, we get one of the first, official recommendations from the American Society of Echocardiography regarding how to assess diastolic function. And I won't go through this at all in detail. We'll look at the new guidelines in a little bit, but this I just thought was really interesting. This was obviously before a time when I knew anything about echo in 2009. And I was surprised looking back at it to see what the standard assessment of diastology would be in an echo. Obviously others can chime in who were practicing at this time, but among, I don't know if you can see my mouse here, but among parts of the assessment, looking at Valsalva change and E to A ratio, looking at kind of more challenging measurements like the isovolemic relaxation time divided by the time between the E and the E prime waves. So the fact that these would all be sort of routine parts of assessment was new to me. It was interesting, and it was kind of the first stab at understanding how we can use echo to measure diastology. A lot more to come on that in a second. But before I do that, I just wanted to spend a few minutes talking about normal diastole and the physiology of this. I think we talked about this a little bit in some of our lectures, but I hadn't really kind of pinned down in my brain how the physiology works here with normal diastole and with these different grades of diastolic dysfunction. So we'll just talk about that for 1 second. So diastology, complex process, but we can roughly break it down into 4 stages. So those would be the isovolemic relaxation period, the rapid filling period, diastasis, and atrial systole. So with the isovolemic relaxation period, one of the key concepts that will come up later, and I think is a key concept kind of in diastolic function to begin with, is the concept of tau, which is the amount of time it takes for the LV pressure to decay by 1/3. So basically just saying that if you have a long tau, basically a long time to decay, that's consistent with impaired relaxation. Then you get to the rapid feeling period, again, complex and energy intensive period that is, been a ton of research into the number of factors that affect this period, but just kind of at a high level, we can talk about active relaxation. So that's resequestration of calcium into the sarcoplasmic reticulum using the Circa pump, which might ring a bell for some. There's elastic recoil, which is dependent to some extent on collagen and titin and restoring potential energy in those forces. And then LV lengthening, which is addresses sort of responsivity to load in terms of LV lengthening, and that has a lot to do with actin and myosin bridging and how responsive that can be to a load from the left atrium. So that's rapid filling, diastasis, little or no flow, and then atrial systole, where you get some portion of diastolic flow, tends to be bigger in younger, healthier hearts and diminish over time. Okay, so again, this is sort of basics, but it may be worth quickly reviewing just to kind of establish the foundation of what we're talking about with diastolic dysfunction. So just looking at the left atrial pressure waveform, and to briefly review, the V wave is pressure increasing in the left atrium as the left atrium fills with blood against a closed mitral valve. The Y descent is when our mitral opens, you release the blood into the LV, so that decreases the pressure in your left atrium. The A wave is atrial systole, so increasing pressure because you are contracting your left atrium. And then the X descent is relaxation of the left atrium, which lowers pressure, but then also it's starting to get to early systole where your mitral valve is moving downwards. It's stretching your left atrium, increasing volume, and therefore decreasing the pressure. So that's the basic left atrial waveform. If we overlay that with the LV waveform, we can see that we would expect roughly two areas throughout the diastole where we have the LV pressure lower than the LA pressure. So we call those areas of transmitral pressure gradient. Obviously, we need a pressure gradient to create flow. And so we expect there to be roughly two areas in diastole, early diastole and late diastole, where you actually are creating flow because your left atrial pressure is greater than your left ventricular pressure. Okay, so that's normal. And then again, this slide is really more for people who I guess haven't done their echo months yet or haven't done much of it. So, one thing that we can do to measure flow through the mitral valve, measure flow from the LA to the LV is use pulse wave Doppler. So basically telling the echo machine to focus on a particular point on the screen to measure flow and velocities of flow. And so we put the sample volume right at the tip of the mitral leaflets there, and then we measure flow. So when we do that, we expect an early diastole there to be flow through this area, and we see that with what we call the E wave for early diastole. And then again, with atrial systole at the end here, we expect flow again, and we see that when we use pulse wave Doppler here, and we call that the A wave for atrial systole. Okay, so this is just kind of something that was helpful for me to walk through stepwise in terms of what is changing in the LV and the LA in the various stages of impaired diastolic function. So we don't really use the 1A, 1B distinction that much anymore, but I wanted to include this just because I found it useful to understand the physiology here. And I'll go through this in a pretty high level way. It's a bit of a simplification, but I think helpful in terms of understanding E to A ratios. So when we go from normal filling to grade 1A filling, we basically have delayed relaxation of the LV. And you can see that on the insert here, basically the dotted line being delayed relaxation. You can just see the slope is less severe, and we call that delayed relaxation. What that does, if you can see these little arrows that I popped in here, is it shortens the gradient between the LV and the LA. So not only does it shorten this this difference here, the delta, but it also lengthens the period over which this happens. And so you can see when we look at the E wave on a transmitral Doppler flow, that's going to make the gradient less, so flow less and velocity less. That creates a shorter E wave, but it also creates a longer E wave. So you have prolonged period as well as a shorter wave. Okay, so then we have residual blood left in the left atrium because we didn't do a good job in early diastole ejecting that into the LV. But in grade 1A filling, we think that the left atrium is still a healthy left atrium that can appropriately respond to Starling forces. There's more blood and does a better job at ejecting all that blood at the end of diastole. So that creates this bigger A wave at the end. So this is kind of ultimately how we get to E to A reversal in grade 1 diastolic dysfunction. 1B filling would be the slight distinction is that your left ventricular pressure increases by the end of diastole. So that means that when you're at the atrial portion of this, your LV pressure has increased by this point. And the main effect here is that you have equalization of pressures between the LA and the LV earlier, and because the LV pressure is high, and that just shortens the A wave. So the main distinction between 1A and 1B is increased LVEDP, and that shortens the A wave. And you can see that in these diagrams at the bottom. So that's grade 1. Grade 2 is shown here on the right, comparing this to the 1B. So the main distinction here is that you have higher LA pressures. So even though your LV pressure is higher as well, your LA pressure is even greater throughout diastole, which was not the case in the grade 1 dysfunction. So you have higher LA pressure. This now creates more flow because we have reestablished the size of this gradient between the LA and the LV. That makes your E wave bigger. And then you also have, so that's there, and then you also have a rise in LV pressure sooner. So this shortens your E wave as well. So whereas in 1B filling, we had shorter and longer E wave, now we have a taller and shorter E wave again. And then similarly, we have residual blood in the left atrium, but because of chronically elevated LA pressures, the LA is diseased at this point and will not do as good of a job ejecting blood because of that. And you also have less of a pressure differential at the end of diastole because of the high LV pressures. All of that creates a short A wave. So this is, you know, this pseudo normalization. The pattern looks similar to normal diastolic flow, but is a disease state and looks similar just for completely different reasons. And lastly, we have grade 3 filling. This is really just grade 2 plus. I mean, it's just a more severe form of grade 2 impairment where the LA pressure is even higher. So the difference between your LA and LV is greater. You have an even bigger E wave. You have worsening left atrial dysfunction that creates a really weak atrial systole. Your LV pressure is really high at the end of systole. And so your A wave is much smaller and you just have a greater ratio between the E and the A wave. Okay, so hopefully that wasn't too tedious for people that already knew all that, but that's kind of the basics here. So now looking at all this, I think, you know, that it sort of makes sense on a physiologic perspective. And so we might say, you know, are we just done here? And we can just look at transmitral blood flow. We can look at the E to A ratio. We can look at the A wave duration, E wave duration, and kind of establish what the grade of diastolic dysfunction is. And as we all know, that's not the case. Instead, we have this. So this is the is clip from the 2016 American Society of Echocardiography guidelines. And, you know, this is, even though the document is actually quite long and really detailed, this is kind of what I think most of us as fellows rely on when we're grading diastolic function. And this is what I have been relying on as well. And I kind of just realized as I was looking at this like complex chart with a lot of different factors in it. And I didn't know that I really understood what each of them were describing, first of all. And then second of all, I didn't really know if any of them were valid or kind of like what the data was supporting them. So that's what I'm hoping to talk a little bit about now. And I hope that'll be useful. So we can start by just saying, why can't we just use the E to A ratio? And I think a lot of us are familiar with the limitations of the E to A ratio. One that a lot of us have heard about is sort of an athletic heart, so a young, healthy heart, which does such a good job at relaxing the LV in early diastole that it creates almost this suction-like effect that creates, a ton of flow in early diastole, a large velocity. So your E wave is huge. There's not so much blood at the end. Your A wave might be smaller, and so you have a large E to A ratio that looks almost like grade 3 dysfunction, but is actually just a very healthy heart. So that's one exception to how we can use this. With hypertrophic cardiomyopathy, we just know empirically that your E velocities don't really correlate well with filling pressures, so we can't use it in this setting either. Tachycardia and AV delay, we may have an E and an A wave, but they're sitting on top of each other. We can't actually distinguish them reliably enough to get good measurements. For fib and flutter, we don't have an A wave to measure, so we can't produce E to A ratio. In mitral stenosis, the velocities through the mitral valve aren't really reflective of filling pressures as much as they're reflective of mitral valve pathology, so we can't use it here. And then, of course, like greater than moderate MR, we think of as a limitation with this. I think of this similarly to when we're trying to assess aortic stenosis and significant AI. The high velocities through the valve are less reflective of filling pressures as much as they're just related to regurgitant volume flowing through the valve. Okay, so lots of limitations to the E to A ratio. So what else can we use? So another one is E prime. Again, just quick review for people who haven't really done echo yet. So what we can do is something called tissue Doppler. So instead of putting the pulse wave sample at a place where we're measuring blood flow, we're measuring tissue movement with the pulse wave Doppler. So we can put this at the hinge point of the mitral valve at the septal annulus, and we'll do the same as well at the lateral annulus, and we can sort of look at movement of the myocardium. When we do that, we get this, in a healthy heart, we get this typical waveform here. So a number of different spikes, your E prime in early diastole, your A prime in late diastole. You have a systole spike as well, that's the S prime, and then bordering the S prime wave, you have these kind of biphasic spikes on each end that correlate with isovolemic contraction and relaxation. So this, measure kind of intuitively to me made sense because it's actually looking at how the LV relaxes in diastole, and it kind of seems to be one of the more direct measurements of relaxation, which is what we think of as being a healthy diastolic period. If we went back and looked at that patient with amyloid, sometimes this just jumps off the screen. Without even doing the measurement, you can just see that there's no relaxation. I mean, it's just not moving in that direction at all during diastole, and it kind of jumps off. You don't even need the measurements before you know you're going to have a low E prime velocity. And so for me, this kind of made sense, but there's limitations here too. So we can't always use this. Again, significant MR is a limitation here. We can't use this because of the increased lengthening load with the regurgitant volume. Mitral stenosis creates a couple different issues. Your E wave tends to reflect, again, the mitral valve pathology more than anything. And then if the apparatus is rigid, then you're going to have a decreased E prime velocity. Similarly with annular calcification, if we really have anything more than mild calcification, your E prime is really just reflecting that tethered myocardium there because of calcification, and really doesn't reflect relaxation at all. With a left bundle or with pacing, or you could include in this also scar from MI, you don't have normal LV movement. It's less of a reflection of overall diastolic function as much as it is just impaired movement or abnormal movement there that creates a less reliable E prime. And then last, constrictive pericarditis. Probably something that comes up in some of our lectures, where your lateral E prime is restricted because that area is tethered to the diseased pericardium, and then the medial E prime is hyperdynamic, kind of compensatory to that. We call that annulus paradoxus, and then creates just kind of unreliable measurements in terms of measuring diastology. Okay, so then we get to E to E prime. this comes up in a couple different places on the diagrams on the left. And this is just a ratio of two of the measurements we've already talked about. This was one where I realized I really didn't understand what this was supposed to reflect. I mean, it's, kind of something where I was reporting it without ever really thinking, why were we putting these two measurements that we've already used into a ratio? And, why is that helpful? You can sort of think of this as an indexing of the E prime, or of the E wave velocity. So you're indexing it against the movement of the myocardium. And I think that was my basic understanding, but I didn't really know, is that empirically reliable? What does that really mean in a more detailed sense? So I'll just spend a couple slides talking about that. As I was starting to research this, I found this like massive trove of literature that relates E to E prime with various outcomes. So outcomes in STEMI, outcomes in catheter ablation for AFib, outcomes for hypertrophic cardiomyopathy, outcomes of exercise capacity in CKD, AFib, stroke. So all of these different outcomes have been correlated with your E to E prime, which is really interesting to me, but I still didn't really get it. I still didn't know, is it actually reliable for diastology? So I was researching, like, what does this actually mean, your E to E prime? And I saw this like very detailed explanation that I won't bore you with too much, but I thought was just interesting as an example, where this group was arguing your E velocity is directly correlated to your LA pressure. That makes sense. So high LA pressure, you're going to get faster blood flow, to the LV. So directly correlated there. Your tau, again, that's like a longer tau means more impaired relaxation. So your E velocity is going to be inversely correlated there. Okay, so that made sense to me too. Similarly, your E prime is just a measurement of relaxation. So that's inversely related to tau as well. And they said, if we rearrange and substitute and all that, we get this explanation for E to E prime, which is that it correlates inversely with left atrial pressure. So this sort of made sense to me. I'm maybe not the strongest math student anymore, but it's kind of wondering, like, these are all just sort of correlative. Can we really just substitute things in for each other and make sense of this and say that this is reliable? Probably makes more sense to look at some empirical studies for when people have correlated with invasive measurements. And there was actually a great a meta-analysis on this. So this is 2016. And a really interesting meta-analysis where they got, I think it was like 16 different studies. And what they did is they looked at the various E to E prime ratios, the mean, the septal, and the lateral velocities. And they looked at, does an elevated E to E prime correlate with, and then you can just see here the measures in various measures of invasive invasive measures of filling pressure. So LVEDP, wedge pressure, pre-A, similar to LVEDP. So I just pulled out, one of the findings here, which is that the specificity was good. I think you can call that good at 0.91, but sensitivity was really poor. Even though it's nice that we put together a meta-analysis, I actually think probably the key here is that, and what I'll conclude with later, is that it's probably more important to figure out who this does work with and who this doesn't work with, than to say whether this works on a population scale or not. I think that appropriate application of these measures is kind of the key for getting a reliable reading on diastolic function when you're doing an echo assessment. And so as much as this is interesting, this has really poor sensitivity, maybe not so surprising, because we're just pooling a lot of unrelated patients and it doesn't tell us much about who it works for and who it doesn't. All of these patients, by the way, had preserved EF. So there was another smaller study from 2015 here. So this is 50 consecutive patients admitted for decompensated heart failure, mix of HFpEF and HFrEF. And these are all patients that had a right heart cath as well as an echo during the hospitalization. They just did a retrospective analysis. They actually found that there was some correlation for patients with preserved EF, but not a lot of correlation for reduced EF here as well. So some question as to how reliable this is, but I think, again, more important in terms of kind of nailing down who we can use it for reliability and who we can't. I'll briefly just talk about the other measures that are in the 2016 guidelines that we use a lot and what some of the limitations are. So left atrial volume index, we have a couple of different measurements, or a couple of different ways of measuring left atrial size. And so, I think people can use one or the other. I think I'm more used to using the areal length technique, but a number of limitations with this. One, just in terms of your echo assessment, I think can be fraught with difficulties, but then there's also limitations based on which patients you can use this in. Athletes, patients who are sort of chronically bradycardic, high output states, like our sickle cell patients or anemic patients, certainly heart transplant patients and patients with mitral valve disease, we may be looking at a large left atrium, but not at all related to diastolic function. Similarly, we use the TR velocity. This is, going on the idea that if you have elevated left side of pressures, you might be able to see those elevated pressures on the right side as well. Often helpful, but there's limitations as well. You need to really know, does your patient have pulmonary vascular disease, pulmonary parenchymal disease that's going to give you a high pressure absent any issues on the left side. Okay, so these are the main things we're relying on in the 2016 guidelines for echo measurements of diastology. And I just wanted to pull these out because I wanted to point out that they're not necessarily all really measuring the exact same thing. So your E prime, like I mentioned, seems to be more of a direct measurement of actual relaxation, whereas some of the other measures are really more about measuring filling pressures. These are related, but not necessarily always the exact same thing. So, your E to A ratio is kind of looking at a combination of the relationship between LV and LA filling pressures. Your TR velocity is really looking at the left atrial filling pressures, the left atrial volume. This is like this chronic measurement of LA filling pressures. And then your E to E prime, as I talked about, it's kind of this idea of an indexed filling pressure, or maybe it's kind of an overall estimate of LA pressure. But each of these measuring related things, but not necessarily all the same. And I think it's important to recognize that we're not just measuring pure diastolic function when we do these echo measurements. On the whole, it's a little bit more of a measure of filling pressures, but some kind of combination of the above. And there are a million different other things that we can use as well. So I'll just highlight some of them here. So tons of different measures of diastology in echo. And I think that we have more than we can really use here. I mean, we can't really maybe easily incorporate all of these into a single study. And I think that was a little bit of the shift from the 2009 guidelines to the 2016 guidelines, is trying to streamline this more. But I think it's somewhat useful to look back at some of these other measures and understand at least what they're describing, and as things change, which ones are we going to focus on, and for which patients are they going to be most reliable. So I'll just highlight a couple. This is diastolic MR. So when I was, I think like in 6th grade, one of my friends told me that the way that elite athletes are so efficient is that most of them have figured out how to breathe in through their nose at the same time that they're breathing out through their mouth. So I spent like a week of my life trying to figure out how they were doing that and trying to do it myself, until, of course, I found out a week later that my friend was just pranking me. So when I was an early first year fellow and one of my attendings mentioned that a patient had diastolic MR, I kind of just like slowly nodded my head and waited for them to start laughing at me. But it turns out diastolic MR is actually a real thing. The very brief explanation here is that it's not throughout diastole that you're having MR, but because of excessively high LV pressures at the end of diastole, you have this brief puff of blood into the LA because the pressures have increased so much by the end of diastole that you have a little bit of retrograde flow at the end. Hopefully that clears it up for anybody who was like me and still not getting this. For the fans of M mode, that creates this little B bump, which if we're doing M mode across the mitral valve leaflet, is probably reflective of that little puff of blood at the very end of diastole. So an interesting M mode pattern there. Okay, so that's one thing that might come up that we can look after. Probably used more often is the pulmonary vein Doppler flows. And I think something that often we are looking at but not necessarily always directly incorporating into our report of diastolic function, but just again, really briefly, when we're looking at blood flow into the left atrium from the pulmonary veins, your S wave is roughly reflective of the pressure gradient between the vein and the LA. So low LA pressure, without elevated filling pressures, you're going to have rapid flow from the vein into the left atrium. But as LA pressure increases and chronically increases, you're going to have blunting of that S wave. So that creates reversal of the S and D, and S to D ratio of less than 1 can be predictive of left atrial pressure. But just like our other measurements, definitely a lot of limitations. So MR, atrial fib, even really preserved EF, this is thought to be less reliable because the robust annular descent can create this reversal in the absence of any increase in filling pressures. So then the other measure that they're also using the pulmonary vein, the AR and A duration. So the AR period is basically the period when the atrium is contracting. Most of the blood flow is going to go through the mitral valve, which because the LV should be a more compliant structure than the vein, but you will have some regurgitative flow into the vein that we can measure on pulse wave here. As your LV becomes less compliant, more blood is going to go retrograde into the vein. And so your AR period is going to get longer. And then going back to some of those first slides that I showed you, your A wave is also going to get shorter as the LV becomes less compliant and has higher pressures. And so collectively, this is going to increase this measure, which is the AR duration minus the A duration, and greater than 30 milliseconds is reflective of increased LVDP. Another measure that we can look out for is called the L wave. So this is abnormal mid-diastolic flow. So basically going back to normal diastole, just thinking about diastasis and how we wouldn't expect flow here. But if you have really markedly prolonged LV relaxation, this is going to sort of bleed into the mid-diastole period, and you might actually have flow here. Often hard to see, can be seen at low heart rates or an AFib when we don't have the A wave to cover up the L wave here. You can see them normally, but if they're small, they can be normal, but anything greater than 20 centimeters per second can be abnormal. And then E-wave deceleration time is something that we've been using a lot. The reason I wanted to highlight this one, I found this interesting study. It was just 35 patients, but all patients with AFib, severe cardiomyopathy, really low EF in all of them. And during a hospitalization, they all had a wedge pressure measured and they had an echo. And so, as we talked about at the beginning, your E-wave deceleration time can be reflective of filling pressures. In early impairment, it lengthens and then it'll shorten as we get to more increased filling pressures. So in grade 2, and 3, we have a shorter and shorter E-wave deceleration time, which can be reflective of increased filling pressures. So the reason I like this one is just because there was a really strong correlation in all these patients across a range of deceleration times that correlated with their wedge pressure. And I just thought it was, this is an old study, it was like 20 years old. And I think it's just reflective of the fact that these measures may be highly reliable in some patients and not so reliable in others. And I think that's part of what we need to understand more is which of them we can apply in which situations. Okay. Again, I don't want to get too wonky here, but I think this is useful to just briefly discuss because it has come up in guidelines before. So talking a little bit about tau, which is the time for LV pressure decay. So longer tau means longer time to decay, which is impaired relaxation. So how can we estimate this? How can we measure this with echo? So one thing that we do is we measure the isovolemic relaxation time, and we can say that as your tau increases, the time for relaxation, for isovolemic relaxation should lengthen as well. So I think that hopefully is somewhat intuitive. As the LA pressure increases, this will decrease because you'll open your mitral valve earlier, which is going to shorten your isovolemic relaxation time. it then has been empirically studied that this very short time interval in between the beginning of your E wave and the beginning of your E prime wave correlates well with your tau. So this has just been studied empirically, and we know that basically as that time lengthens, so will your pressure decay time. Rearrange everything using math, and then we get this, which is that the isovolume relaxation time divided by the time between your A wave, beginning of your A wave, and your E wave, sorry, and your E prime wave is inversely correlated to your left atrial pressure. So this is, I think I showed you at the beginning in the 2009 guidelines, was considered part of the standard evaluation of diastolic function in a patient using echo. The reason I think it's used is because it's independent of a lot of other factors. So mitral valve area, compliance, relaxation do not factor into this. And it's looking at this narrow time period, which is thought to be highly correlative of relaxation. And there's, I think, a real strength there, but the issue is that it's really hard to measure. You have to measure this like 4 different times during the study, and their heart rate kind of has to be roughly the same in all of them. So you have to have really experienced echocardiographer and then a patient whose heart wants to beat at the same rate for the entire study. Just not that easy to do. And because of that, not going to be so reliable. Okay, so wrapping up here in the next couple of minutes, I just want to briefly talk about strain imaging, because I think this is going to be part of what we use in the future. When I started searching for this, I actually saw the first thing that came across was correlating systolic strain to diastolic dysfunction. I just found this interesting, so I'll briefly show you. Again, for those not familiar, strain is looking basically at LV myocardial movement throughout different phases of the cardiac cycle by doing something called speckle tracking. So basically looking at these echo speckles and tracing them from one clip to the next to seeing how much they move with greater movement downwards or in various directions, considered to be a higher strain value. So this is a sub-study of the Paramount study, which was looking at ARNIs versus ARBs in patients with preserved EF over a 12-week treatment period. And I'll just show, they looked at both longitudinal and circumferential strain. The red bars are longitudinal strain, and you can just see here that LV systolic strain was actually correlated with people that were thought to otherwise have heart failure with preserved EF. Okay, I'm going to go through these last ones quickly since I'm a little bit running out of time here. Probably more sort of physiologically reasonable is looking at left atrial strain. So the left atrium has a number of functions: a conduit function, a reservoir function, and a booster function. All of these are important for diastole. All of them can be disease, and we can look at strain throughout the atrial cycle here, with peak strain being during the reservoir function. And if we look at strain in these 6 different segments, we can kind of get this really detailed measurement of strain throughout diastole. I liked this paper just because they found this really beautiful correlation between there's really high strain in normal patients and really low strain in patients who were otherwise considered to have diastolic dysfunction. So definitely maybe something that we're seeing in the future. And then finally, we can just look at diastolic strain of the LV. And this is a study that looked at ICU patients with decompensated heart failure. Some of them had normal EF, some of them had depressed EF, and they looked at 3 different ways of measuring diastology. So one is just your standard E to E prime. Another is E to E prime that, rather than using tissue Doppler, actually uses speckle tracking, which may be slightly more reliable. And then finally, we use diastolic strain. And this is just to show that in this study, they got their best correlation basically when they used diastolic strain. And then there's another study showing this as well that I'm going to skip through just for the sake of time. So that's what I have for you today. I'm going to stop talking. I'll briefly share some conclusions. So a few things I learned as I was researching this: most echo measures really estimate filling pressures, which approximate but don't necessarily directly describe diastology. We have more measures than we can reasonably use in routine care for diastology. The current guidelines, the 2016 guidelines, try to streamline all of these measures into something that's useful for us, but have limitations. And then lastly, my own thought is that using more studies to correlate invasive measurements in certain populations will help us understand kind of which measures are most reliable in which situations. And I think that's going to help us understand when some of these measures are reliable and when the newer measures like LA strain and LV diastolic strain could be useful for assessing diastology. So I had a lot of great conversations with people about this controversial topic, and just highlighting Dr. Thames and Dr. Anura, who were helpful in helping me kind of shape my thoughts on this when I was at Grady last month. I will stop here. I will take comments, questions, angry rebuttals if anybody has them. Thanks for your time.
Thank you, Colin. That was very good, very comprehensive review of a very complex topic. I'm more of a comment, I guess, and I think just to highlight a couple of things you said that I agree with. That I think the key, as you mentioned, there are a multitude of ways to assess diastolic function. No one is anywhere close to perfect. They all have significant limitations. That's why we have 20 different ways, all these different ways people have tried to do it over the years. They all have significant limitations. And I think the most important thing is understanding the limitations of each individual modality of measuring diastolic function, which you highlighted nicely. And it's just, it's almost like assessing diastolic function is there's a lot of, I don't know. I mean, it's just taking all these different factors into account and just sort of, and not just, not being, it's important to not be wed to any one given measurement or any certain algorithm, and to just sort of assess everything in total a lot of times and just give your best sort of gestalt assessment of things, and you're also looking at things like the patient's age and LV wall thickness and, this and that, and then, taking into account the image quality and all these different sort of nuanced things that go into it that it's very difficult until you just have time and experience reading a lot of echoes to get a grasp on. I mean, I'm still frequently flummoxed trying to figure out someone's diastolic function. So it's incredibly difficult and complicated. So I don't really have a question. It was just that comment highlighting what you said. It's really not even so understanding the algorithm is just the very beginning. It's more understanding each individual measurement, what it means, and its particular limitations.
Yeah, I totally agree with that. I think one of the changes I noticed after I started researching this was that I just felt more empowered to not report, a diastolic grade for more echoes, just because there are so many times where it really doesn't work, and you're not going to be helping whoever ordered the study or the patient by taking a guess that doesn't apply. So yeah, I totally agree with that.
I think the other quick comment I have is in the new guidelines, part of the point was also is to try to make the point that not all patients that have an E/A ratio of less than 1 or 0.8 or whatever it may be necessarily have a disease state of their ventricle.
Yeah. That
there is a quote unquote sort of normal group of people that may have a E/A ratio of less than 1, but it's just part of normal. If their left atrial size is normal and their ED prime ratio is not very high and their TR velocity is normal, it doesn't mean that we're giving a lot of people diastolic dysfunction that probably just had normal aging.
Absolutely. Yeah.
This is Neil Dickert. So this is a really great talk, and I think nicely highlights the fact that there's just so many measures that it's hard for us to know what to do with. One of the things that I think is really important too, and this is a bit of a tag on to the last comment about the E to A ratio, is that you kind of, it's like these are a series of branch points in so many ways, and you have to really watch what you choose as your first branch point. Yeah. Right. So if you start, just as Robbie mentioned, if you start with the E to A, you're immediately going to go down the track of starting with people with an assumption that many people have abnormal diastolic function, and that's going to be wrong. I think, one of the things I think is somewhat reflected in the newer guidelines, and you got at this as well, is that I think you have to think about this as many different measures, and you have to start with some sense of pretest probability, right? So you know, if the EF is abnormal to start with, and you have other evidence of, you know, particularly LV disease, you know that your pretest probability that they have normal diastolic function is very low. The challenge though is sort of when to kind of use that and when to start your branching. But I think that this notion of kind of a pretest probability based on all the other data is a really helpful way to think about how to use each of the tools. And I think it's just like a lot of other tests. You know, I feel like in the CCU, one of the things we tell the residents a lot is, you know, you're going to get one or two conflicting numbers every time you look at, so whether it's, you know, some combination of renal function, blood pressure, different measures of hemodynamics, you got to figure out which number you're going to ignore for the day. Yeah. And there's a sense in which I think you have to do the same kind of thing with diastolic function. And a lot of it is about sort of what your pretest probability is. And one of the limitations, I think you're right, that we can't always report it. One of the limitations is we don't always have enough clinical data as an echocardiographer to be able to contextualize every patient. When we can get it and when it's really important, I think that's really important to try to do. But sometimes we don't have that.
Yeah, I think, you know, that's something a lot of our attendings will be teaching us, you know, as we're learning to read echoes, is that, you know, reviewing the chart is an important part of this. I think this is like really true for diastology, because that is where you build your pretest probability. And totally agree with you. Without that, you can just be heading down this pathway of, you know, starting at the wrong branch point and you're coming up with something that doesn't make sense for the patient at all. And I just saw in the chat, Elena was asking about, since the measures are flow dependent, asking if routine Valsalva for diastolic assessment is useful. I'm definitely not an expert, but from the little that I read when I was reading about this, it seems like Valsalva, you know, looking at ETA ratio during a Valsalva is fairly reliable measure, and it did exist in the 2009 guidelines. My impression, or maybe assumption, was that the reason this wasn't carried through is just because it's hard to do. I don't know if others can weigh in on that, but it seems like it would be something that's hard to do reliably. I mean, I just think about even like the sniff for, you know, IVC size, like we so often don't believe that it's a real sniff or the patient can't do it or whatever it is. And so I was wondering if that's why that kind of dropped out, but to be honest, I don't really know.
Yeah, I mean,
Colin,
go ahead.
No, you go ahead.
Robbie? Yeah, I was going to say, my sense is it was probably just more of a simplifying sonographers' lives, but it was a good, I mean, if someone had a normal ETA ratio in Valsalva and then their E wave dropped significantly and they developed this sort of ETA less than 1, that would suggest that was grade 2 diastolic dysfunction versus someone with normal diastolic function. Their ETA ratio would remain greater than 1. So we used to do that in the past, but I think it was more of a time saver. And it was technically sort of difficult to do, to get good images while someone was Valsalving at times.
Right.
The other piece is it only helped with a pretty minor recategorization.
Right.
You know, it didn't get you into the normal versus not.
Yeah, right. Yeah. You're just distinguishing pseudonormalization. I guess the idea is we now have other measures that can help with that anyway. So maybe, yeah, less important.
Hey, Colin, this is Mon Jokadar. I have a major objection and issue with everything you said. Diastolic.
I knew I was going to get one of these.
Diastolic dysfunction is very sexy, if you ask my opinion. Okay.
All right. I had to pick the middle of the road here. It's too controversial.
Well, but all jest aside, I think you have to ask yourself, why even bother assessing diastolic function?
Yeah.
And I think it's to look at the practical applications, which are myriad. Assessing prognosis, assessing filling pressures, valvular disease, ventricular dysfunction, assessing therapy. For example, if you have someone with hypertension and normal diastolic function, you may be more conservative than someone who has mild diastolic dysfunction and hypertension, where you may be more aggressive. Right. If you look at survival data from just people in population, Dr. O and colleagues published a paper years ago out of Rochester that showed if you had diastolic dysfunction your risk of death in 5 years was 10%, which is crazy, or 20%, I think it was, if I remember correctly. And so for those folks, you may want to be more aggressive. If you have someone with a cardiomyopathy that responded to therapy, say a peripartum cardiomyopathy, and their systolic function normalized, but their diastolic function didn't, that might be someone that you may want to continue on medical therapy. So what I'm trying to say is there are a lot of practical reasons for why to assess diastolic function that I think are worth highlighting and thinking about as we report. And then, when it comes to saying indeterminate, I shy away from that. And sometimes I'll say it's probably abnormal, but I can't grade it. Right. Or probably normal. I'll do my best to guide the person, not to necessarily give a disease, but it may help explain dyspnea or other symptoms, et cetera. So my personal bias is to shy away from the indeterminate as much as possible, except in situations where you simply just cannot evaluate, like mitral stenosis and transplant, et cetera. But congratulations on a great talk. You did a really good job synthesizing a complicated and very important topic.
Yeah, thank you. I appreciate that perspective a lot. I think that, right, using how we can then use this assessment to help the patient is definitely at least a whole separate talk. But one that, part of why I wanted to start here is because of the fact that, I knew early on that it was useful. It comes up so much on our advanced heart failure rotations where we actually really find this useful, and circling back to my 94-year-old patient who's in clinic and doing completely great. It probably doesn't really matter so much, but there are so many others where we would change management based on this. And that's something that I need to learn more about, but I think, your perspective is very valuable there.
And a second really quick comment is the 2016 guidelines. They were designed to dumb it down because the 2009 were too complicated for many.
Yeah.
And I have an issue with that.
Yeah.
Hey, Colin.
Yes.
Steve Clement. So, Robbie, you and mine still on? Yes.
Yep.
So I was somewhere at a meeting and about diastolic dysfunction, and the first speaker was Naguib, who is first author on the guidelines, and the second speaker was Tony DeMaria, who's one of the grandfathers of echocardiography. So Naguib goes through these guidelines with the algorithm and very elegantly. And one of the first things he said was try not to say indeterminate. It's very easy to do that. And then here comes Tony DeMaria, and he gets up, and the first thing he said was, "Gee whiz, that's a hard act to follow." And now I'm going to give you some practical points to think about. So one bottom line of that is that we all have to study the guidelines and study what we know about diastolic dysfunction. And it is one of the most, trying to grade it is one of the most confusing areas in echocardiography. But it is a great pleasure to see a young athlete who's got an E prime lateral of 22 or 18, and that's very reassuring. And then when you see someone with a thick ventricle and an E prime of 4 or 3, then that sends you a message.
Uh-huh.
So we need to study it. Also, in one of your slides, the second one showed an L wave. You got to watch the sonographers because they'll measure that L wave in atrial fibrillation as an A wave. And you'll find the calculations up there in the E to A being really the E to L. And I've seen that many times, so you can watch for that. A very good job. Thanks so much.
Thank you. Appreciate that.
All right, Colin, for the sake of time, I think
Yes,
we'll wrap up here.
Thanks for the comments, everybody.
Thanks everybody. Thank you, Colin, and look forward to seeing everybody next Friday.
The preceding program is copyrighted by Emory University.